Hello, my name is Andrea Fidziak, and today I will be presenting a case about a patient diagnosed with a paraneumonic pleural effusion. All right. So, Mr. Trachea is a 61-year-old Caucasian male with a 40-pack year smoking history. He presented to the ED from home with his wife, complaining of right-sided sharp and stabbing chest pain at rest and exertion, as well with 2 to 3 word dyspnea at rest and exertion. So the past medical history for this patient includes uncontrolled COPD because patient reports no use of puffers at home. Um, to note as well for this patient, he has really poor dentition and oral hygiene with most of his teeth either rotting or missing, as well as dysphagia, esophagitis, gastroesophageal reflux disease, for which he takes Pantoloc, um, and also a not yet diagnosed lung lesion located in the left lower lobe. He also disclosed at triage that about 2 weeks ago he went to his family doctor and he was prescribed some antibiotics for pneumonia. He had been compliant with taking antibiotics for about a week, and then he went back to work for a week until he felt this chest pain and he came into us. So, assessment and diagnostics. So he presented to the ER about around 3:30. So these were his vitals on admission. Definitely very hypotensive, with a blood pressure of 83 on 52, tachycardic with a heart rate of 113, uh, very short of breath, very tachypnic, with shallow breathing. He was statting around 71 on room air. So the nurse threw him on some nasal cannulas at 3 liters per minute, and that gave us a stat around 93%. Um, for the more detailed RT assessment, he was definitely diaphoretic, moderate work of breathing, with accessory muscle use. He was alert and oriented to person, place, and time. On auscultation, diminished air entry to the right middle lobe, absent air entry to the right lower lobe, but clear on the left. From the ER, they ordered some blood work and some imaging. Things to note on his blood work that were really jumping out or relevant um, were his lactate that was really elevated. It was at 3.3, so that indicates some sort of there's some sort of interruption to of oxygenation to the tissues, as well as an elevated white blood cell count, which usually indicates some sort of infection going on. At a chest X-ray that found a large consolidation, a 75% whiteout to the right lung with atelectasis, and the left lung was clear. The initial CT found a large pleural effusion extending to the right apex, collapse of the right lower lobe bronchi, pleural parenchymal scarring and thickening, as well as moderate emphysema that can be due to the COPD, not necessarily due to the pleural effusion. But definitely something to note, as well as compressive atelectasis found in the right lung, also probably due to the pleural effusion. Before we get into the treatment and this patient's management at the hospital, I want to touch on what the disease is so that it makes more sense as we go through his hospital stay. So, um, there can be two different types of pleural effusions. It's either transudative or exudative. Transudative, it's usually due to an imbalance in homeostatic, homeostatic and oncotic pressures. It's usually seen more in patients with CHF or with ascites due to cirrhosis. So we can look more into the exudative side of things. There is different kinds of exudative pleural effusions, like subcategories. So we can also, we're also going to take a look at that to better manage our treatment. The most important thing for a differential diagnosis, excuse me, is looking at the patient and reviewing their past medical history. So, as we know, our patient is known for GERD, dysphagia, esophagitis, poor dentition, poor oral hygiene. He's had a recent pneumonia infection, um, as well as a lung nodule located in the left lower lobe. This lung nodule actually has been controlled by his family doctor, and he gets imaging done every once in a while just to keep track of it. So the uh, nodule hasn't been large enough to biopsy, and it's very stable on multiple scans he's had in the past. No signs of nodal metastatic disease, so it's less likely to be malignant, and less likely to be transudative based on past medical history alone. Based off of the imaging he had done, um, he did have a period of deterioration there. So the patient deteriorated in status about 5 hours from first presentation. And this is, I'll go in more into detail for that, but at that point, the ICU team was consulted as well as our team, and they did end up putting in a chest tube after that imaging to drain the pleural fluid. So we can talk about the pleural fluid results and how that helps into the differential diagnosis. So it came back with a positive gram stain. So what does that really mean? So the gram staining assesses the specimen acceptability for further processing. Another result that we got from the pleural fluid, it showed elevated levels of LDH. So LDH stands for lactase dehydrogenase, and it's an enzyme that's released in the blood when cells are injured, and it usually happens due to inflammation secondary to infection. Um, there was also a growth a growth of Strep constellatus. So this specific bacteria is part of the normal flora of your mouth and gut, but um, studies have shown that this bacteria can cause respiratory tract infections and parapneumonic effusions as well as abscesses. So, as well, going back to past medical history, this patient doesn't have the best track record for um, good oral hygiene. Um, and the last point that came from our pleural fluid culture was the pH. So, the pH was 7.0. Usually, a pH of less than 7.2 indicates to a more complicated and involved parapneumonic pleural effusion. And I'll go into that a little bit more in the next slide. We narrowed it down to it's an exudative pleural effusion, but where do we go from there, right? Because that doesn't really tell us how to treat it. So parapneumonic pleural effusion specifically refers to the accumulation of exudative pleural fluid, which this patient has, associated with a same side lung infection, usually bacterial in nature. So the pathology mechanism of this is the inflammatory response to the lung infection increases the vascular permeability and leads to leakage of the protein-rich fluid and immune cells into the pleural cavity. There are three categories for parapneumonic pleural effusions. The first one is uncomplicated. It's the mildest and earliest form. So definitely exudative and neutrophilic. It usually has a negative gram stain and negative culture. The pH level is above 7.20 and has usually low inflammatory markers. It's usually treated with antibiotics and resolved. Second category is a more complicated. So this is when It happens when the bacteria actually enter the pleura at a very low count, so they're not causing a pus formation yet. So because they're at a low count, we can expect to see a negative culture. The pH will be less than 7.2 with an elevated LDH due to a little bit of increased inflammation from the immune response. These usually require drainage and antibiotics. The very last one is the advanced and most severe. It's empyema thoracis. So this is when frank pus is found in the pleural space. So, and we can find evidence of bacterial infection of the pleural fluid, which will then correlate with a positive gram stain and a positive culture. So the treatment for this one, it's a little bit more involved and a little bit more aggressive, and I will go into it as we go along. But just as a sneak peek, it includes drainage, fibrinolytic therapy, chest tube irrigation, and surgical intervention. Now is when I would like to talk about our patient's compensation there. So the patient deteriorated in status about 5 hours from presentation. He was very agitated, altered LOC. He was ripping off the leads, ripping off his clothes, not really, very confused, didn't know where he was really. Um, Increased work of breathing seen with very shallow respirations, increased O2 requirement. He was put on a non-rebreather just to get a SAT of 92%. Very hypertensive, blood pressure was 111/64. Some sort of respiratory fatigue. His respiratory rate was 14 and heart rate was 106. So patient was admitted by medicine and ICU and RT were consulted. The initial interventions, intubation, so oxygen support, ventilation, and oxygenation due to respiratory failure secondary to the pleural effusion. So the patient was intubated by the RT on first attempt via glide scope with a grade 1 view using a 7.5 ETT with EVAC, positioned at 25 centimeters at the teeth, with positive color change on exhalation, air entry to the left, diminished to the right, but that's more likely to be from the pleural effusion. Patient was manually bagged with the BVM. And noted by the RT that he was very difficult to ventilate. Second intervention, as I mentioned before, is how we got our pleural fluid in the first place, a chest tube insertion. So the chest tube was inserted by the resident for drainage of pleural fluid. They chose a pigtail chest tube, was inserted to the right chest laterally at the level of the fifth intercostal space. So pigtail catheters are smaller in size. They're usually a size 12 to 14 French. They're more flexible. I think they chose this one because it's a smaller catheter, so it's less traumatic, less invasive. Also easier to manage for pain, and it's associated with a higher initial output volume, reduced risk of surgery, and a shorter tube duration. So for these reasons, they chose the pigtail catheter as the initial chest tube. And as we know, one of the major complications from chest tube insertions, especially if you're a resident that hasn't done very many in the first place, is perforating the lung and causing a pneumothorax. So this is exactly what our patient sustained during the first chest tube insertion. This is when the RT noted it got exponentially harder to ventilate. So to drain the air from the pleural cavity, a second chest tube was inserted, an Argyle chest tube at the midclavicular line at the level of the third intercostal space by the physician. So these Argyle chest tubes have a larger bore. They're usually 24 to 40 French size for more, and they allow for more flow to drain, and they are less flexible to reduce kinking. So upon the insertion of the second chest tube, a gush of air was heard. When attached to the collection chamber, bubbling was seen, and an initial 1 liter of pleural fluid was drained and sent for cultures. Um, Upon insertion, RT noted compliance improved and manual ventilation was easier at this point. So a second chest x-ray confirmed chest tube and ETT placement. And the third initial intervention that we did for this patient was to, of course, to set them up on a ventilator and to be transported to ICU for closer monitoring. So initial settings, we put this patient on ACPC with a 36 over a PEEP of 5, respiratory rate at a rate of 12, 100% FiO2. And the data that we got from the ventilator was very high pressures, a P peak of 41 with volumes of around 400. Patient was being ventilated with a minute volume of 5 mils per kilo, and the SpO2, the highest that we could get it to was 78%. We tried repositioning the patient with head of the bed at 30 degrees, but he did not tolerate that. He desatted right away. So he was only tolerating supine and low PEEP. He was in ICU. The vent settings changed. PNSP was around 22, PEEP of 8, at a rate of 12, still on 100%. And the patient was noted to be breathing above the ventilator at a rate of 20. So pressures did come down with a P peak of 31, was minute ventilation increased to around 7.8 with an SpO2 of 92. So for the night, the patient was stable throughout the night on these settings. Another intervention that I didn't talk about on the PowerPoint, but definitely to note, is on the nursing side, the pharmacological support that we gave this patient. He was not hemodynamically stable after the intubation, so he needed a little bit of vasopressor support. So he was on norepi and vasopressin to maintain that blood pressure up. He was, of course, fully sedated and paralyzed with Versed and Nimbex. And for pain management, due to those chest tubes, managed with Dilaudid, as well as wide spectrum antibiotics with piperacillin and tazobactam and vancomycin. So he was put on wide spectrum antibiotics for day 1 of ICU. An event occurred in the very early hours of the morning, around 1:30 in the morning. The RT was called for a patient desaturation that required manual ventilation again. So the RN told the RT that she had just turned the patient on to his right side. And the RT educated the RN and suggested to reposition patient back onto his left side. So this is called the good lung down approach. It's very important to consider patient positioning in patients with respiratory failure and the causing pathology behind it. So in the case of our patient, the right side is our bad lung, meaning most of the alveoli are not participating in gas exchange due to compression atelectasis, or of course they are filled with pleural fluid. So when the bad lung goes down, these units are not seeing ventilation, but they're seeing more perfusion due to gravity. So it causes a shunt. So by employing the good lung down position, we're improving the matching between our V and our Q, so our alveolar ventilation and our perfusion. So that's exactly what we did. After the patient was put back on his left side, his SpO2 improved to 92. Other notable things that happened on day 1 of our ICU stay was an insertion for a femoral art line so that we could get our first ABG. So our first ABG was obtained around 6 in the morning. It came back as normal with a low O2, a low PaO2, but still acceptable. So it was 741, 39, 76, and a normal bicarb of 24. So our SaO2 also to note was 98%. So we decided to titrate our FiO2 instead of 100%. We landed on 70 with an SpO2 of 96. Prior to that, it had been 98 on 100%. Repeat chest x-ray around 8 o'clock. It showed a large amount of air removed from the right pleural space, a small amount of residual fluid in the right lower pleural space. Second CT was also obtained around 2 p.m. It showed patchy areas of consolidation with airspace disease in the left lower lung, which again could be to the COPD. There were new ground glass densities, subsegmental atelectasis in the right middle lobe, and emphysema in both lungs. The two chest tubes were correctly positioned in the pleural cavity, a small residual pneumothorax in the right side, some mild thickening of the right visceral pleura, trace left pleural fluid collection, and some overall improved aeration of the right lung. And the pleural fluid results, like I said before, gram stain positive, growths of strep, constellatus, and lots of leukocytes present. Day 2 of ICU stay, which would be January 21st. So the patient was weaned off of sedatives around 6:30. Our 6 o'clock gas was alkalotic. It was a respiratory alkalosis. Our pH was 751. CO2 was 28, so we were overventilating. Our PaO2 improved to 105, and our normal bicarb of 22. Other blood work to note was our white blood cell count was still elevated at 24. Lactate improved to 1.8. Patient presented still under sedation effects during that time. No cough present, no gag, not following commands, no eye opening. Was trialed on CPAP, but did not tolerate and went apneic. Because of the alkalotic ABG, we tweaked some stuff. So the new settings we got were PNSPUF 16 with a PEEP of 8, rate of 10, FiO2 of 30, and the values that we were getting from our ventilator, our peak pressures with great improvement at 29, and ventilating with a minute ventilation of 7.5, and volumes unchanged remained in the 400s to 500s. So we had a repeat ABG taken around 3 o'clock just to see if our changes helped, and it came back to what you see on the screen, so 7.40. Our CO2 was 41, O2 was 85, and bicarb was 26. So no further changes were made. Number 4 in the ICU. So our 6 o'clock gas came back metabolic alkalosis. So again, he had remained on the same settings, and the new gas was 7.51 with a CO2 of 36, which is normal. PaO2 of 122, and an elevated bicarb of 29. Patient still off sedation, so he was found to be very awake and alert, oriented only to person, following commands. So he was trialed on pressure support ventilation, which he tolerated. So We presented these new findings to the ICU team during rounds. I had a discussion with the doctor during rounds, and we agreed to do a mode change for this patient to PAV plus with a support of 40%, PEEP of 8, and FiO2 remains at 30. Values that we were getting from our ventilator after the mode change. So he was a little bit tachypnic with a respiratory rate of 25, volumes of around 360 to 400, minute ventilation of 8, compliance was 48 with a resistance of 1.6. Our pressures, peak is 14. So we had a repeat ABG later on in the day. It came back to a compensated ABG. So our pH is it's normal with a 7.44. CO2 is also normal with value of 43. Our PaO2 looks great at 116, and our bicarb continues to be elevated at 29. Talk about PAV Plus because it's an advanced mode of ventilation, and compare it to PSV and see what the differences are and what the benefits are. So, as we know, pressure support ventilation, it's usually considered the current standard of care for assisting breathing patients during the recovery phase of acute respiratory failure. So how PSV works is that the ventilator detects the patient's effort to inhale, and the clinician sets a fixed amount of pressure. And so when the ventilator senses the patient taking a breath, the pressure is sent and it's delivered to assist the patient's breath. So this can lead to having more dysynchrony, and also the patient doesn't have to work as much to trigger a breath. So there's less patient workload, which contributes to respiratory muscle wasting and weakness, and therefore a prolonged hospital stay. So this is where PAV Plus comes in. So it stands for proportional assist ventilation. It's designed to support patients that are breathing spontaneously by providing assistance that's directly proportional to their own respiratory effort. So unlike PSV, PAV continuously monitors a patient's compliance and airway resistance and adjusts the level of support in real time. So it's ever changing and it's a breath to breath support. Measures the patient's compliance and resistance by using the equation of motion. So as you know, the equation of motion relates pressure to volume, flow compliance and resistance, and PEEP. So it does this by introducing little pauses to analyze how much pressure is delivered and is required to deliver a certain volume and how quickly that pressure rises with flow. So from this, compliance is calculated, and as a change in volume over the change in pressure, while resistance is being derived from the change in pressure divided by the flow rate. So these values are automatically and continuously updated, enabling the ventilator to quickly adapt and change due to changing lung conditions and deliver that proportional assistance that closely matches the patient's efforts and needs. So what this means pretty much is that the patient has to make a stronger effort to inhale so that the ventilator provides help. When the effort is lighter, it provides less help. So the clinician sets a percentage of assistance that determines how much of the work of breathing the ventilator will take on. And this approach improves synchrony, patient-ventilator synchrony, reduces the risk of over or under assistance, and preserves respiratory muscle function. So PAV is particularly useful in the weaning phase, as well as it feels closest physiologically to spontaneous breathing and is also more comfortable for the patient. Continue on our timeline here of our ICU stay. So day 5, which would be January 25th. At this point, the pigtail chest tube showed some intermittent bubbling, but no fluid output, and the Argyle chest tube was draining around 200 to 300 mils of pleural fluid a day, so not too much. Um, and it also showed no bubbling. So the pleural fluid culture analysis came back, and again, it was showing high LDH, indicating exudative with the growth of Strep constellatus, as we also discussed earlier. On the blood work, white blood cell counts were more elevated at 25, and this is when the doctors decided the most likely source would be the patient's poor dentition and oral hygiene. Um, so now that they knew the exact pathogen that was this patient was growing, the wide spectrum antibiotics were discontinued and replaced for clavulin, which is a more specific treatment antibiotic for this bacterium. Um, as well as the Argyle chest tube was trialed, so they clamped it and then discontinued. So this patient was extubated to high flow on the extubation criteria that this patient met and did not meet. So the patient was awake, alert, following commands, had a cough and gag, and of course was on PAV with minimal support and improved oxygenation and ventilation since um, day one. But however, the extubation criteria that was not yet met was the underlying pathology was not resolved still. The infection was still active. We were still getting persistent white thick secretions from the ETT. The patient was still on vasopressors, so he was not hemodynamically stable on his own. Um, there was also poor pain management, so this led to the patient having a suppressed or weak cough, which was, I think, the biggest reason of why this patient failed extubation. So, like I said, the patient was extubated on January 25th and started on high flow with an FiO2 of 50% at 50 liters per minute. On day 6, which was January 26th, a very notable event. So, in the middle of the day, the patient had a drastic desaturation from 96% to 85%, with decreased chest rise, increased work of breathing. So the patient was reintubated and manually ventilated, had an emergency bronchoscopy, which we found copious thick white secretions in the right and left main stem bronchi. So we did some pulmonary toileting, and a bronchial alveolar lavage sample was obtained from the right middle lobe and sent for cultures. After this, the SpO2 improved to 95. As well as a chest x-ray was retaken, and it showed a worsening pneumothorax. As you can remember from a little bit earlier, I said that they had trialed and removed one of the chest tubes. So the Argyle, the big thick chest tube was reinserted, and again bubbling was seen in the collection chamber, as well as subcutaneous emphysema was noted to the right arm and anterior chest. T suggestions for bronchial hygiene were employed, so head of the bed at 30 degrees as tolerated by the patient. We recommended some that our physio friends come in and join to give some chest physio, as well as they had a percussion bed available. So this is helpful to loosen the secretions along with the chest physio. And we also recommended some stronger pain management because the patient was only on Dilaudid at that point. And again, like I said, he was complaining of a lot of pain, so that left to him not wanting to cough as strong as he could have. The patient again was left on PAV plus 40% support with a PEEP of 8, an FiO2 of 45. He was left stable. So then we can jump on to day 7, January 27th. The patient was extubated again as per physician's order. We continued bronchial hygiene measures like I spoke about, and he was again restarted on high flow at 45%, 50 liters. At this point, this patient was very agitated, restless, reports of pain, unwilling to cough, and the BAL results came back and showed no growths, no fungal elements, just a few leukocytes. Day 8, um, the chest x-rays, so that would be January 28th. We had another chest x-ray and it came back as a full whiteout of the left lung with a persistent pneumothorax on the right side, as well as a persistent subcutaneous emphysema noted. The blood work for that one also showed continuing to climb white blood cell count. It was 27.8, with also climbing lactate of 1.9. Because the patient had an art line in, we could obtain an ABG. It was a metabolic alkalosis, so it was 7.52, CO2 of 37, O2 of 67, and a bicarb of 30 with SaO2 of 98% on 45% O2. To assist also with the pulmonary toileting, an NPA was inserted in the right nair for deep suctioning. So the patient was encouraged to cough and to help manage secretions. We were still getting that thick white secretions from that. Last day, at least myself with this patient in the ICU. So we continued those bronchial hygiene measures, and the the ICU team was sort of at a stalemate. They really didn't know what to do with this patient. So they consulted with the thoracics team over at the Ottawa Hospital, the general campus, um, to see if this patient was a good candidate to have surgery. The thoracics team reviewed this patient's case and they concluded that this patient was not a good candidate for VATS due to the existing pleural thickening and scarring. He had the comorbidity of COPD, as well as this patient, because of his dysphagia and the esophagitis that I spoke about, this patient was very, very thin, malnourished, and already weak. So these were all things that would not make him eligible to have surgery. So the thoracics team suggested chest tube irrigation, fibrinolytic therapy, and after those treatments were given, they would reassess. But he was not eligible. Chest tube irrigation was administered. So 100 mils of warm normal saline were put into the Argyle chest tube, and we got 100 mils back. And 100 mils were also injected into the pigtail, but we only got 30 mils back from that one. The patient tolerated it well, but there was no real benefit seen from the irrigation. Chest tube irrigation is a therapeutic technique used to maintain or restore drainage of the chest tube that may become obstructed, often due to thick fluid. So, like I said, this patient had the worst case, or the most developed case of a parapneumonic pleural effusion. So most similar to an empyema. So we were wondering if maybe we weren't getting fluid back because of a clot or something that was obstructing the chest tube, as it can be quite thick. Um, so by instilling the sterile normal saline into the chest tube, fluid is mobilized and loosened to promote more effective drainage. The fluid is allowed to dwell after injection for a few minutes before unclamping the tube to facilitate return of flow. Usually the benefits seen from this procedure include prevention of persistent infection, and though preemptive surgical interventions like chest tube irrigation can be helpful. It has not been proven to show much benefit like it happened with our patient here. So another suggestion that we also employed from the thoracics team was fibrinolytic therapy. It's TPA administered. So TPA is a mixture of alteplase and Dornase alpha. So these two chemicals work synergistically to dissolve the fibrin strands and the purulent clots that could possibly be blocking drainage of the pleural cavity. Um, it's important to note, though, that the timing of administration within the disease timeline is important. So fibrinolytics are most beneficial at the earliest stages of the disease process, where the fibrin clots are still fresh and easier to break down. Some studies conducted with fibrinolytic versus placebo groups showed some reduction in therapy failure and reduction in surgical intervention, but no significant change in overall mortality rate. That's I want to talk about. It's also a treatment for perineumonic pleural effusions, and this is what we initially asked the thoracics team consult for to see if this patient was eligible for it, but unfortunately he was not. But I would like to talk about it regardless. So VATS stands for video assisted thoracoscopic surgery. So this is a minimally invasive surgical technique. They usually just do two incisions in the intercostal spaces to get into the chest cavity. And it's used to diagnose and treat conditions, including lung biopsies, lobectomies, pleural effusions, empyemas, and pneumothoraxes. So instead of having a large open thoracotomy incision, you insert a small camera and a specialized surgical instrument through the incisions in the chest wall. And this approach typically results in less post-op pain and reduced hospital stays and faster recovery compared to an open surgery. So patients considered for VATS, again, have to meet a specific criteria. So they should be hemodynamically stable, have no extensive adhesions or severe pleural thickening, which our patient did have some thickening and scarring. And they have to possess adequate pulmonary and cardiac function, which our patient also did not because he has COPD. So these criteria are in place so that the patient is able to survive and tolerate single lung ventilation that's employed during this procedure.